Good afternoon, everyone, and welcome to the Neuromuscular Monitoring webinar on this beautiful Thursday afternoon. My name is Stephanie Perez, and I'm the European Sales Manager of Savant and hosting this live webinar today from Malaga in Spain. And I hope you are all well, and wherever you are, all over the world, even though this webinar is mainly attended by Europeans. And for your records, we have over 300 registered to attend this webinar, which is a fantastic number, and you are welcome. And for now, over almost 100 of you have logged in already, and hope you had time to grab your coffee and to sitting comfortably to enjoy this webinar. And meanwhile, others are logging in. I'd like to thank Savant Technology for supporting this webinar today, and also to the chairman, Rocher van Rensburg, and our IT support, Mias Visser, who are as panelists attending this webinar. And of course, a very big thank you to our faculty, Professor Dr. Heidi Lewald and Dr. Grant Rodney. So this is an educational meeting to show and teach about the important aspect of the widely known recommendation of the quantitative neuromuscular monitoring during the anesthesia using neuromuscular blocking agent to prevent postoperative residual paralysis and its related complications. And for this webinar, I'd like to introduce you first to our first speaker, Professor Dr. Heidi Lewald. She's professor of the anesthesia at the Department of Anesthesia and Intensive Care Medicine at the Technical University of Munich in Germany. So she has a background in basic as well as clinical research, and her scientific focus is the neuromuscular junction, pharmacodynamics and kinetics of muscle relaxants and the reversal agents, as well as neuromuscular monitoring. She's also member of the guideline task force of the ESAIC, the European Society of Anesthesiology and Intensive Care, who just developed the first European guideline on perioperative management of neuromuscular blockade. We are looking forward to hear your presentation. Thank you very much, and enjoy the lecture of Professor Lewald. Thank you.
Well, thank you so very much, Stephanie. And I'm really excited to be part of this webinar. And when I saw the results of the poll, I thought maybe I'm specifically aiming at the 37% who said that they don't monitor. But of course, it's for everyone. But it was very interesting to see the results of that questionnaire. If we get started on background and evidence, of course, I would like to, in the beginning, just say that, as you probably know, this webinar is entirely sponsored by Savant Technology, and I'm also receiving a speaker's honorarium. But also in the past, I've received speaker's fees from GE Healthcare and from MSD. But most importantly, I'd like to emphasize that I'm not advocating one device over another. I really just simply advocate and endorse using quantitative neuromuscular monitoring. We have different monitors and different muscle relaxants and different reversal agents that we have available that basically allow us to safely manage neuromuscular block, but we just have to really know what we're doing. And even more important, we just have to use them. But as a first step towards that goal, I think that we as an anesthesia society and every single anesthetist amongst us, we just have to be aware that there's really some room for improvement when it comes to neuromuscular monitoring, and that we have to acknowledge that we might have a blind spot in our clinical practice when it comes to residual neuromuscular block. And to put this into a figure, I brought you another questionnaire that was published a couple of years ago. And in that questionnaire, our colleagues were asked if they think that there was a problem by asking them if they've ever observed a patient with a clinically significant residual neuromuscular block in the recovery room. And if you have a look at the answer, it makes it seem as if there was no problem, because in 90% of cases, our colleagues in the US said no, and in almost 80% of the anesthetists in Europe, they answer that they have never actually seen this. And if you look at the overall estimated incidence of clinical significant residual block, most of the answers are it's below 5%, and the highest bars were even at the below 1% answer. Now, to be honest, I think that this questionnaire kind of shows us what we would hope for, and is kind of the wishful thinking that we have. Because if you look at the facts, you see a completely different story. There you go. I'm sorry. You see a completely different story, because that was the most recent study that was published. And what you can see is that the overall incidence of residual neuromuscular block is 65% in total. And it's also discriminating between academic hospitals and community hospitals. And you have the incidences of 60 to 83% with the red bar, that is a train of 4 ratio of below 0.6 being the largest bracket. So the facts really show you a different story than we would hope for. And the question, of course, always then is, why is this so? And first of all, I think it's very difficult for us to admit that we actually have a problem, that we would maybe have to change our daily routine, how we induce anesthesia, how we monitor during anesthesia. But the most important problem, I think, is that we're kind of taught in a different way. And because if we look into a textbook, what you would actually see is that, there are certain times given for duration of action of muscle relaxants. And of course, we would depend on that. We rely on that. But we kind of ignore that there is this huge inter-individual variability of the duration of action of muscle relaxants, and that the duration of action is simply unpredictable in our patients. And just to give you an example, I brought you a study that we did in our own hospital, and that was in abdominal surgery. The patients were relaxed with rocuronium, and then until the fascia was closed, and then the time was measured until the train of 4 ratio recovered to 0.9 and above. And what you, of course, can see is that the average time for a patient to recover to that train of 4 ratio of 0.9 above is about what you can read in the textbooks, and that is about 45 to 50 minutes. But you can also see patients that are way above that are over an hour, and sometimes even up to 2 hours. It takes them up to 2 hours to recover from their neuromuscular block until we're able to extubate them. And that is just a problem that we're facing in our everyday operating room. And no one's immune to residual block. No anesthetist is immune to, or no patient is immune. And you've probably all seen it. And I just wanted to share a video with you that I saw the day before yesterday. And I thought that would fit very nicely into this webinar. And that is, we have this young lady, or I was called to the OR by the nurse because one of the residents had asked me to come because this lady was breathing kind of funny. And this is what I then saw. And what I saw, what you now saw, is basically a young lady who has difficulty to maintain a patent airway. And I mean, why are we seeing this? The argument, and of course, or the excuse was always the same: a certain time pressure. The case before that was kind of delayed. The surgeon was already nervous. Then you see the arms are both tucked for induction. That one was tucked as well. And then they only realized that they didn't have a neuromuscular monitor on. And then they thought, okay, they'll just use 20 milligrams of rocuronium for a 60 kilogram patient. And the procedure was just scheduled for 30 minutes and then took 60 minutes. So everyone thought that they were actually safe, but apparently they were not. So the next question then, of course, arises, is that actually clinically significant? I mean, you heard that little bit of snoring of that patient, but does that really matter? And I think it does, because if you have a look at muscle relaxants and the risk of postoperative pulmonary complications, what you can see here are the adjusted odd ratios, for desaturation and reintubation, and that how they are higher in the patients who received neuromuscular blocking agents. And if you go even further to the incidences of pneumonia, you have an adjusted odd ratio of 1.8, and that's simply because the patients received a muscle relaxant. Now, if you come from the question muscle relaxants and postoperative pulmonary complication, the next question, of course, is going to be, is it residual block that causes the postoperative respiratory complications? And it appears to be, because here you have two groups, patients who had no residual block at the end of surgery and the patients who did have a residual block. And you see the major complications, meaning desaturations, reintubations, pneumonia, etc., are almost all in the group that had a residual block at the end of surgery when they were extubated. Now, some might think that this is a story of the past because, we have sugammadex now available, although a lot of you also answered the question if they had sugammadex available with no, I think it was pretty much about 50%. But there are some colleagues there who think that we have sugammadex and we've always had neostigmine, so, you just have to administer your reversal drugs and you're fine. But I think that we're not fine if we do that without neuromuscular monitoring, because this study could show this very nicely. There were patients that were not monitored intraoperatively and then were then assigned to one of the three groups, either spontaneous recovery, neostigmine reversal, or sugammadex reversal at the end of anesthesia. And in the post anesthesia care unit, those patients were then double checked what their Trainer 4 ratio was. And as you can see here in the neostigmine group, pretty much every fourth patient had a residual block of Trainer 4 ratio of 0.9 or below. And even in the sugammadex group, this the percentage was 4%, which is still every 25th patient. Now, you might say with neostigmine that as a choline esterase inhibitor, and it has a certain ceiling effect, that this maybe pharmacologically didn't really work out. But with sugammadex, to be very honest, and its unique mechanism to reverse any depth of neuromuscular block, I think that this is, pretty astonishing. And if you go even higher, if you go to a Trainer 4 ratio of around 1 unity or between 0.9 and 1, and we're going to talk about that a little bit later, which actually the best threshold for extubation is, you see numbers which I find totally unacceptable, especially in the sugammadex group with almost 50%. So I really think that muscle relaxation as well as reversal of muscle relaxation is not possible without actually monitoring the effects of both. Now, so we have to delve into neuromuscular block monitoring per se, and we basically have three different options. First of all, it will be clinical tests where you have hand grip, head lift, and so on and so forth. Then you have qualitative neuromuscular monitoring where you visually or tactile assess the contraction of the muscle. And last but not least, you have quantitative neuromuscular monitoring where you have AMG, accelerometry, you have KMG, which is pretty much the same principle as AMG, and you have EMG. Now, I'd like to focus on this image first. Here you have the percent of patients that are able to perform a certain task, and that is plotted against the actual Train of 4 ratio. And what do you have up here, for example, is the tidal volume. And what you can see is that even if the patient has a Train of 4 ratio of 0.2, pretty much all patients are able to maintain or to generate a tidal volume that is adequate. And that was exactly the problem that we had with that patient that I just showed you with the video, that she was breathing fine on the endotracheal tube, but as soon as you took it out, she wasn't able to maintain her upper airway. So tidal volume with an intubated patient is absolutely no good clinical test to detect residual block. Neither is things that we often do, like, could you please press my hand grip. At a Trainer 4 ratio of 0.5, the percent of patients who are able to perform this is about 50%. So you might as well throw a dice. You're not able to discriminate if the patient, or reliably say if the patient has a residual block or not. Clenching teeth might be a bit more sensitive, but then again, I wouldn't want my patients to bite onto the endotracheal tube when I'm about to pull it out. And the most sensitive seems to be diplopia. But then again, I mean, we put some ointment into the eyes and cover their eyes during surgery or during anesthesia. So I don't know how reliable that is supposed to be when a patient just emerged from anesthesia and then he has to tell you if he sees you once or twice. So to make a long story short, none of these clinical tests are really reliable, and all of them are unable to detect residual neuromuscular block. The second possibility we had was qualitative neuromuscular monitoring, and bottom line is also that it's not you're not able to detect slighter degrees of residual block with qualitative neuromuscular monitoring. They're good for deeper levels of block, but if you, for example, look at the train of 4 ratio curve and then actually plot that against the actual train of 4 ratio, at its train of 4 ratio of 0.5, again, you're only about 50% of anesthetists are able to detect that the patient still has a fade. And no matter what kind of stimulation mode you use, they're all far away from the ideal curve where you would be able to detect a fade in 100% of your patients up to a train of 4 ratio of 0.9. So again, qualitative neuromuscular monitoring is also not good for you and your patient to detect residual neuromuscular block. So we have to look into quantitative neuromuscular monitoring. And since this is a kind of a background talk, I just wanted to go over neuromuscular transmission and where we actually monitor what we monitor together with you. So if you go from the action potential down to muscle contraction, our neuromuscular blocking agents act pretty far upstream. What we measure is pretty far downstream with AMG and KMG. And because of that, we might have some kind of mechanical disturbances, what we call mechanical noise, just movement of the thumb, positioning of the thumb that might interfere with that. But we have another option, and that is electromyography, because what EMG does, it actually measures the depolarization of the muscle membrane. And all 3 devices are absolutely great if you actually use them, and it's better to use any 3 of them than none, but you just have to be aware of a couple of things. And the first thing is that accelomyography overestimates the degree of recovery. This is a Blonde-Altman plot where you plot the mean of 2 devices against the difference. Sounds complicated. I'm just going to go over this with you. You have to know, you have to know that everything that is above 0 means that the first device actually overestimates compared to the second device. So for example, if you have an AMG reading of 0.9 and an EMG reading of 0.7, the mean then would be 0.8 and the difference would be 0.2. So you'd be somewhere up here, and that then indicates to you that this device, the AMG device, overestimates the degree of recovery. If we look at EMG, and EMG is nothing else but the calculation of the time interval of the depolarization of the muscle membrane, and as you saw before, is further upstream from your neuromuscular contraction. And you see the respective Blonde-Altman plot, and you know how to interpret it now. You can see that these numbers are all very, very close, around 0. So EMG is a lot more stable, a lot more reliable when it comes to neuromuscular monitoring. Now, the next question, of course, is, does quantitative neuromuscular monitoring really have an effect on the patient, on an outcome? Does it really reduce the critical respiratory events that we saw before, desaturation, so on and so forth? And this was a study that's been done 14 years ago, but it really nicely shows it. What they did in this study was they had 2 groups, AMG monitored patients and patients monitored with peripheral nerve stimulators, so qualitative neuromuscular monitoring, and they called these the conventional group. What you can see first is that these patients were monitored in the operating room and then double checked in the post-anesthesia care unit, that the patients that were monitored with a simple nerve stimulator had higher incidences of lower degrees of residual neuromuscular block firsthand, and they also had a lot more episodes of critical respiratory events, these being either during transport from the operating room to the PACU or in the post-anesthesia care unit. They also had a significant higher percentage of critical respiratory events. So as you can see here, quantitative neuromuscular monitoring is really able to reduce these critically respiratory events. One study is good, but if you pool studies, it's even better. And this meta-analysis by Hugo Carvalho came out 2 years ago, and he could show that quantitative neuromuscular monitoring together with intermediate acting neuromuscular blocking drugs, and those are those that we use these days, rocuronium, cisatracurm, atracurm, had the lowest incidence of post-operative residual pluralization. Long-acting muscle relaxants would have been pancuronium, but I don't think that anyone uses pancuronium anymore these days. So the good thing about everything that I said so far is that a lot of guidelines have already taken up these studies and the results of these studies. And the one that came out last year in the UK from the Association of Anesthetists was one of the most advanced recommendations and boldest recommendations, which we kind of really celebrated because what they said was really fantastic for the first time. And that was that quantitative neuromuscular monitoring should be used whenever neuromuscular blocking agents are administered. That kind of makes sense, but the good part is that it should be used throughout all phases of anesthesia from before initiation of neuromuscular blockade until recovery to the train of flow ratio to 0.9 or above has been confirmed. So really you have to put your neuromuscular monitoring device on before you administer a muscle relaxant and take it off when the train of flow ratio is 0.9 or above. And as you heard in the beginning, I'm a member of this guideline committee, and we're also going to bring out guidelines at the beginning of next year. And one of the recommendations is going to be that we recommend the use of quantitative neuromuscular monitoring at the adductor pollicis muscle to exclude any residual paralysis. And these are only two guidelines that I showed you, but there are numerous other national societies that have made similar statements. And so it is pretty much acknowledged these days that neuromuscular blockade monitoring is mandatory every time you give a muscle relaxant to your patient. So this being said, I don't think we have to be more explicit when it comes to neuromuscular block monitoring. There's no miracle, it's no rocket science. We just have to do it with every patient that receives a muscle relaxant, not only for us, but especially for our patients. With that, I really would like to thank you for your attention. And yeah, thank you for joining this webinar. I'm going to hand back to Stephanie now.
Thank you very much, Heidi, for this amazing lecture. So it was brilliant. Thank you very much. And as I said before, all the questions they may raise from your lecture, we will answer after the second speaker, Professor Dr. Rodney Grant. So now we are going to present you our next speaker. If you put your camera on, thank you, Dr. Rodney. So you heard his name already several times. He is consultant anesthesiologist at the Ninewells Hospital in Dundee in Scotland. And you will notice in his lecture that he has a particular passion for neuromuscular monitoring in enhancing clinical practice. He's involved in device evaluations, training, education via scientific meetings, seminars, and webinars as the one we have here today. He's member of the Association of Anesthesiologists Working Party for developing standards of monitoring, and he made his publications back in 2015 and 2022 about mandate quantitative neuromuscular monitoring for patients receiving paralytic drugs. He's busy with ongoing quests to promote and ensure effective, clinically relevant monitoring of patients under anesthesia. With this said, the stage is yours, Dr. Rodney. So we're looking forward to hear your lecture. Thank you very much for your attention.
Okay, thank you, Stephanie, for the introduction. Now I'm just going to put this into a slide presentation. I'm sorry. Can you see my slides and hear me okay?
Yes, we do. So. Thank you.
Yeah. So thank you. I live in Scotland. Yeah, some pretty pictures. It's a very small city, a long way from many of you in Europe, with some nice natural surroundings and a growing culture and environment to be. I'm going to move from the very knowledge-based and academic and excellent presentation from Heidi to just add some practical elements to that, and how I believe we can manage neuromuscular block. I'm interested to see, just first of all, by way of disclosure, I am a twitcher. There are two types of twitchers. I like both. I'm an active member, or have been, of the working party from Association of Anaesthetists for the last 2 publications on their standards of monitoring documents. And just as with Heidi, I am fantastically enthusiastic to endorse quantitative monitoring, whatever that product might be. So my thanks to Stephanie and the Savant team as well for the support of this webinar. In a short period of time, I'm going to touch on the guidelines. There will be some overlap with Heidi's work here. A little bit more, again, about some of the monitoring modalities that she mentioned. A few practical tips and how this can tie together with a strategy. I was very pleased to be involved with developing guidelines, as Heidi has mentioned. And it's just to confirm that these just published really moved forward quite significantly with a statement to say that quantitative neuromuscular monitoring should be used through all phases of anesthesia. And you've heard this from Heidi, and most particular to start at the beginning and finish at the end. And the importance of the end is to remove that risk of postoperative residual paralysis and potential harm to patients. So if we just break down these phases a little bit, it's very interesting that still today in my department, my colleagues, there is still an issue with applying the monitor at the start. We did an interesting across Scotland SNAP audit of practice some years ago, and you can see that just under only 10% of anaesthetists applied that monitor at the start of the procedure, and not all used it throughout. And most commonly, it's just put on at the end. So, I mean, why bother to put it on at the start? And it's actually very straightforward. I'm not sure why it presents a challenge, but it does. It takes probably 10 or 15 seconds for most devices, and it fulfills a number of purposes. Firstly, when it's activated, we know the monitor's working. We confirm the electrode positioning and that it's not causing a direct muscle stimulation. It's indeed stimulating the ulnar nerve, for example. It establishes a baseline and allows for calibration if it's a product that requires that. It allows us to refine that massive variability in onset of drug that Heidi showed you, so that we can optimize the quality of what we're doing at induction and intubation due to that huge patient variability. I'm running a couple of short video clips, which will show in this particular one on the left hand, the patient's hand has an accelerometry device applied. You can see the probe on the finger. The patient is anesthetized, the device is activated, it's stimulating every 15 seconds. It's said not to require calibration, so the accuracy of the train-to-4 ratio on induction unparalyzed isn't so important. It's really that target at the end. Very easy to apply, start the button, then paralyze the patient when they're anesthetized. Here's another device, just an example, in this case, an electromyography device that I'll talk a little bit more about. Here you can see it's testing out and a supramaximal stimulus and then delivering an initial train of 4. If you watch it running again, the start button is activated once the patient's anesthetized, detecting a supramaximal current and then a baseline train of 4. And everything follows on from then: onset of the drug, recovery, need of top-ups, and maintenance. And skipping on to the end, which is ultimately the key aspect about emergence and extubation. And again, the statement that we've said repeatedly and will continue to say, that patients should remain anesthetized and not awakened or extubated until the train-to-4 ratio is returned to a minimum of 0.9, and that can only be assessed using a quantitative monitor, whatever your choice of reversal agent is, and we'll come on to those. So there are a host of devices out there on the market, and if you happen to have a blank checkbook to go and buy them, there's a lot of choice out there. Most of us don't have a blank checkbook, certainly in the UK anyway. I'm not going to dwell on kinemyography and the trainer for cuff, but the major choice for most of us boils down to acceleromegraphy and electromyography devices. And this consensus statement, I'd recommend, it's published in 2018, and it's a very, very sensible outline of the case for quantitative monitoring, but also the understanding and recognition of the challenge of getting to that. So I think 50% of you in the poll said you don't have these devices. And there's a host of considerations, acceleromegraphy versus electromyography. Heidi's highlighted some of the differences between those, and I'll elaborate. There can be freestanding devices that can move around, or they can be integrated into your monitoring system. And in many ways, it's easy to incorporate them. It's just not always clear whether that's necessarily the best device. And then some of these products require disposables and revenue costs, so you need to consider the costs of both the purchase and the disposables. And then I think there's a huge amount about how reliable they are, how robust they are, how easy to use. If they take a lot of time to complex setup and calibrate, we know it's not going to work in our busy clinical practice. And this is about buy-in, and then about manufacturer support. So the monitoring sites, the ulnar nerve, obviously it is key and is most widely used. The posterior tibial nerve can be used, the facial nerve as well. I'll come on to the facial nerve, but just a little bit about arms tucked surgery, and I'm sure your practice probably isn't different to mine, where more and more of our patients seem to require to have their arms inaccessible. And so the issue with that is an acceleromegraphy device cannot give you reliable readings, and I'll elaborate on that. The facial nerve, I have serious misgivings about using that, and again, we'll come on to that. So you're really left for arms tucked surgery and continuous monitoring during procedures with EMG products and the neuromuscular TOF cuff, which I don't have time to dwell on. So this study by Tillin showed that there's actually there was a 5-fold greater incidence of residual paralysis in patients receiving anesthesia with neuromuscular block in comparing facial nerve monitoring with use of the ulnar nerve. And there's a number of reasons for this. The supramaximal stimulus required is very low. It's easy to directly stimulate the muscles. And this muscle, the frown muscle, if you like, the corrugated supercilii, behaves like the diaphragm and the larynx, so it's resistant to paralysis. So it's very easy to detect twitch responses, paralyze patients in response to that, but actually their ulnar nerve level of paralysis is much, much deeper. So a word of caution about using the facial nerve. In my own practice, I just don't use it. So delving a little bit more into acceleromegraphy, and again, I appreciate the audience of delegates. You come from a variety of countries, and pitching this too low, too high at the right level is obviously challenging. So Newton's law, this is based on force equals mass times acceleration, and this sensor is measuring a muscle acceleration and generating a voltage which is proportional to the force of contraction. And that is then displayed on a monitor as a trainer for count, or a ratio, or indeed other modalities like post-tetanic count. And calibration is said not to be required by the manufacturers of some of these more modern 3-dimensional sensors, which account for the triaxial thumb movement on stimulation of the ulnar nerve. As I said earlier, they can be freestanding or integrated. There's very little running costs because they just require a few cents or a few pence of standard electrode, ECG electrodes. But there are some caveats. And one of the key ones is that impedance of thumb movement. So this patient is at the same level of block, having 15-second stimulations. And the image on the left, the arm is by the patient's side, so the thumb can't move freely. So you will see 4 twitches or movements, but the device is only recording 2 out of 4. But when the thumb is moved away on the right, actually you can see there are 4 twitches present. There's fade present, and that ratio is around about 20%. So it's absolutely vital that any reading that's taken or acted on, that the thumb is positioned so that it's not interfered with. And here's another interesting concept with acceleromegraphy, the issue of reverse fade. So the baseline measurement of an AMG very often is over 100% and can be quite significantly over it. So arguably, Heidi's already shown that the recovery of AMG perhaps is, or is, not perhaps, is ahead of the actual level of recovery if you're measuring it with an EMG or indeed the gold standard research device, a mechanomography. So many would have that, that actually 0.9% should be a normalized 0.9% of 120%, which is 108%, which is a rather challenging concept, I know, from trying to get this across to colleagues. And here's just a quick run through. This is an awake simulation. It's my own ulnar nerve being stimulated. And it shows one device, the Prof scan, which truncates that at 100%. So you never get a reading higher. The Zavant StimPod displays the raw data and deliberately does so. So in this case, it's displaying 120% as a baseline. So I think there's a word of caution with AMG that says, given that reverse fade issue, given that advanced level of recovery, that we really should be aiming for as high a ratio as we can, ideally unity as a minimum. Back to the consensus statement from expert users that quantitative neuromuscular monitoring should be used. And it was the view of this panel that in fact, the best or the ideal device is actually an EMG or electromyography device. The challenge we have as working clinicians is if you have AMG and not EMG, I urge we use that to its optimum benefit. If you have none of these, obviously the challenge is how you get to any of them. So EMG, as Heidi showed, this is a different level of measurement in relation to that neuromuscular function, a measure of muscle action potential, which is generated by the muscle contraction after neurostimulation. And it reflects an electrical event at that junction. So it's beneficial and useful when the arms are tucked. It doesn't display the reverse fade phenomenon. It's probably closest to the gold standard research. But like everything, there are caveats and temperature effects readings. Electrocautery is a big issue in terms of interference. And there are proprietary electrodes, and that incurs a cost. In other words, there's a capital outlay for the monitor, and there's a revenue cost associated. But as Heidi said, and apologies for the repetition, but it's just important that quantitative monitoring will always be superior. Here's the Carvalho study again showing that a third of patients with none or only a standard nerve stimulator monitoring experience residual paralysis trend for less than 0.9. Study qualities and so on, there were some issues with that, but it's quite clear, and there's a number of studies showing those benefits. So finally, just delving into a little bit about strategy, and we put together a small editorial in Anesthesia talking about a strategy which incorporates planning, monitoring, and the drugs we use, the paralytic drugs and the reversal drugs. And of course, again, you'd be no different to me in that our patients on a daily basis tend to be becoming more challenging due to age, due to BMI, due to comorbidities. Other factors obviously are the nature of airway management and the surgery type and the importance or need for paralysis for surgery. So clearly we're talking much about monitors and quantitative devices and their benefit, and that needs to tie in with the drugs we have access to. And again, I appreciate the poll numbers were relatively small, but significant numbers. I think it was about half do not have access to sugammadex. And we all await in Europe with interest, I think, to see what happens as that patent expires 2023, I believe, in terms of drug availability from other manufacturers and cost. I think education is absolutely key, and we've produced quite a bit of work around our strategy, around training, around processes for using sugammadex in a cash-strapped environment. And this little low-key T-trolley concept, I think, is an excellent one. If your theatre system allows it, accompanied by some tea, coffee, and cake indeed, with a low-key interaction around operating theatres in the operating room, delivering small-scale practical demonstrations to colleagues. And we've run a number of webinars and seminars through the association. So how's a strategy tied together? So, you know, we've said it repeatedly, a quantitative monitor is required from start to finish. And it's about seeing and observing and not looking and not seeing. And it's this iceberg analogy. We cannot see that broad base in terms of inadequate reversal unless we measure it. So it's also about planning, and plans need to change, as we all know when we go into battle in theatres and surgery, that plans for surgery and paralysis needs may change. And then I think with regards to drug use, there's an issue, I think, with optimizing NMB use and avoiding overuse. And I think this is particularly important if neostigmine is your drug reversal choice. So I think we should paralyze patients when we need them and only then. And these drugs should be based on the ideal body weight and given in the smallest doses with minimized repeat doses. And it isn't me saying that. These are recommendations from the National Audit Project 5, which is about awareness under anesthesia, big projects in the UK. This is just one of many, many recommendations. And the first being essentially that awareness only happens when patients receive NMB drugs. But this is one that says we should plan or suggest we should plan the use of our relaxants very carefully, consider if we need them at all, if we do, when to use them and to what depth. And then reversal, as I said, is going to depend on availability of drugs, correct dosing and depth. And I believe there's a target here, which is that residual paralysis of our patients should and can be a never event. This drug dosing table takes a little going through, and given the time, I'm going to somewhat rush through it. And it's essentially a guidance for the safe practice and best use with neostigmine at different levels of block. So if you look at the columns, the qualitative PNS, just ignore that really, but the quantitative PNS column, this one here we have on the left-hand side, the recognized definition or description for depths of block from very deep to recovery and awake. The post-tetanic count, 0 to 15 is either a complete or deep. Moderate block is where the train of 4 is present, 1 to 3 twitches, and then shallow block where the ratio is less than 40%, minimal block where it's 40 to 90, and then recovery. And I think really probably this amber should be a red for neostigmine reversal, and many would say that a train of 4 count of 4 is a minimum before giving neostigmine. And some would actually argue that that should be a train of 4 count, a train of 4 ratio above 40% before using it. So it's got a very narrow window, and then it needs the correct dose. So 50 mics per kilo for a shallow level of block. There's very few adult patients I have who weigh 50 kilos and would require just 1 vial of neostigmine, 2.5 milligrams. So it needs the correct dose with enough time for that to work. Is there evidence for this? Well, there's a number of studies, and this one from Matthias Eichermann, who's well known to Heidi and their group, implementing a strategy involving neuromuscular blockade. And ultimately, Heidi's question, does it matter, so what, is can you reduce postoperative pulmonary complications, hospital stay and cost? And this very large quality improvement program focused on drug dosing, cognitive aids, education, financial incentives, and a neostigmine dosing table, the likes of which I showed you. And indeed, they showed a reduction in postoperative pulmonary complications from 7.5% of their patients to just over 6%. Arguably, it's not a reduction to none, with lower costs and a shorter length of stay. I just want to start to end with a rather ridiculous statement. It's a stupid thing to say that sugammadex is not a monitor. And obviously it isn't. The key that underpins this is quantitative monitoring. Otherwise, we are guessing. It may be a safer best guess if we're using sugammadex, but the Kentucky study Heidi showed you demonstrates you don't eliminate residual paralysis with sugammadex. So the monitor's key to refine patient and surgical journey, if you like, through the phases of anesthesia, dosing appropriately with paralytic drugs, and then allowing either spontaneous recovery, which can occur, or the use of neostigmine or sugammadex to get us to that ratio of 0.9 or above. That sugammadex is uniquely effective, providing a dose-dependent reversal from any level of block, but still has that variability that needs measurement and monitoring. And I've not got time to go into it, but no drug is without adverse effects. So we should only use drugs when we need them and in the smallest doses. And finally, I've said it with neostigmine, But this narrow therapeutic window means we need a high level of recovery before reversing. A train of 4 count of 4 is a minimum to wait to get there. And then the correct dose given early will ensure better outcomes for patients and safe recovery to 0.9. And I believe if you use the QNMB monitor with neostigmine, it really unmasks this patient variability and really needs us to think very much about how much we paralyze our patients. So in summary and closure, thank you for listening. Thank you to colleagues in Zavant for this. What I would say is that if you've got the monitors in your place and you don't routinely use them, please just try them. Do your normal practice, put them on. If you don't have them, there's opportunities to use the guidance coming from the association and also from the European group shortly. Effecting change in our own practice is challenging and in our departments, but I'm certain it's worth it. It's worth the effort. It's practice changing. And I'm going to quote my colleagues in Zavand. I'm not sure if they will thank me for this, but they have an incredibly lofty goal of eliminating neuromuscular blockades, residual paralysis. It's a massive challenge globally, but I'd endorse that. Thank you for listening, and sorry for running over slightly.
Thank you very, very much. Brilliant, Dr. Rodney, and thank you very much for sharing this amazing lecture with information. So I hope the audience could learn a lot from you, and of course, there may be a lot of questions yet that are maybe not raising here in our webinar, because looking into the chat, we don't have much questions. I have questions from Andrew Murai. Do you think that sugammadex has led to a sloppier NMB management? So I don't know if Heidi or Grant would like to answer Andrew's question.
I'd be happy to do so. Practically speaking, yes, I think that it has become a bit sloppier because it was kind of introduced to the market as this on-off switch. You know, you can give as much rocuronium as you would like to, and you just have to have the adequate dose of sugammadex in the end, and then you're going to be fine. But I really hope that with the Kotaka study that I showed and that Grant also mentioned, where you see that if you don't monitor neuromuscular function, no matter what reversal agent you use, you do have a high risk of having residual block. So I think that it might have become a bit sloppier, but I really also hope that webinars such as this and the education that we're doing is going to make the people aware that it's not an on-off switch, muscle relaxation on-off with sugammadex, and that they go back to the basics and they administer a drug only when it's necessary, A, and B, monitor the effects. Just as well. No one would ever give a antihypertensive drug without monitoring the effects. So why should we give a very potent drug without monitoring what it actually does to the neuromuscular function of our patients?
Thank you very much, Heidi. We have another question saying, if as a clinician I have full and easy access to routine sugammadex usage, which brings my patient back from paralysis in minutes, why do I need to monitor paralytic emergence other than confirmation of greater than 90% TOF? They are practically sitting up after a few minutes of reversal.
I think much of what we said, sugammadex reverses the effects of neuromuscular block extremely effectively, as is pointed out. But it tells us nothing about the onset of that drug, about the patient variability, about the wearing off, about the need for top-up, and about the recovery. And also, it tells us if you are just giving sugammadex without using a monitor, it doesn't even have to be a quantitative monitor. Quite clearly, the company's dosing guidance is based on the measured level of block. So train of 4 count equals 2 milligrams per kilogram, PTC of X, 4 milligrams per kilo, immediate reversal 16. So if we are just completely blind to it, we are just squirting in a drug without any rational idea of where we're coming from, on the basis that it's very effective, and most patients will end up sitting up and pulling their tube out very quickly, as the questioner said. But as Heidi said, there will be small numbers, and arguably it's not that small, 4%. Do we want 4% of our patients to receive an excellent drug and still be residually paralyzed? And I've seen this in practice. So sugammadex is not a monitor.
Great, thank you very much, Grant, for this response. We have just a comment from Kevin saying, excellent presentation, thank you both. And we have a question from Spain, from Javier Silvia Garcia. When using QNM by accelerometry, like the one of Drager, if you calibrate it before administering the NMB, will you be able to appreciate the reverse fade effect?
Heidi, I don't know if you've used this device. I do, and it's one of the challenging things I find with the way we work is that I can't stabilize the patient's hand in the same position usually. So whatever my starting point or baseline is, it's changing with induction and then moving the patients around the operating room and positioning them. So it is possible to do a train of 4 reference with the TOF scan, which gives you essentially displays what the individual twitch heights are of those 1, 2, 3, 4 stimuli in a train of 4 stimulus. And you can visually see the fact that the subsequent 2nd, 3rd, 4th twitches may be of a greater amplitude than the first one, but it doesn't display a number. So I stand corrected, but I'm not convinced that that you can, is the answer to that question. And so and I guess it's one of the many reasons why in an ideal world people support EMG use, and I can't speak for Heidi, but I'm sure she would talk about that. But it's one of the reasons why thinking about relaxation, minimizing your use of that, reversing adequately with time with whatever your choice of drug is, and with the likes of the TOF scan, ensuring that ratio is as close to unity as possible. There's one other little interesting study, and there's some concern, of course, that if you give neostigmine in patients at high levels of recovery, you cause a depolarizing style of weakness. And that certainly seems to be the case in awake volunteers. But I think there was work from Murphy, who, and Heidi quoted an earlier study, where he took patients with, I think it was with AMG at 0.9 recovery, and they were randomized to receive low-dose neostigmine or placebo. And the neostigmine group measurement of muscle strength parameters, a range, was not reduced at all. And in fact, in 1 or 2 modalities were increased. And the accompanying editorial suggested that when you recover to 90%, you still can have 70% of your NM receptors blocked. So if you're just freeing up more acetylcholine there, you're enhancing that. Whereas in a naive NM receptor in an awake volunteer who's not had a paralytic drug, you blast acetylcholine and may cause that muscle weakness. So if I didn't have sugammadex and I had high-risk patients who just got to 90 or even 95 or 100% within a short period of time, I would consider using small doses of neostigmine. Of course, I'd like to have access to sugammadex to use as a routine when I can.
Mm-hmm.
Thank you very much. Looking into the chat for now, there are no more questions, and also to be respectful with your time, it's 6:10. I'd like to hand over quickly to Roger van Rensburg to give him opportunity also to say something. So stage is yours, Roger.
Thank you very much, Stephanie. I really appreciate it. And I feel like I have to say good morning, good afternoon, and good evening if we look at everybody that's present in this webinar. So thank you very much, everybody, for attending. I really just wanted to end it off with Grant kind of touched on it, and thank you for making the reference, Grant. And it is really an important kind of goal and mission for us at Savant. We've really made it our mission to eliminate residual neuromuscular block. And we've kind of given ourselves a timeline to do this in as well. So the entire company is focused in getting this done. And we've kind of split up things into 3 major parts. One of course is product. There has to be a device out there that can do this. But there's lots of devices out there, as you saw in these webinars. And a second part of is kind of a service component that we're looking at. But the third leg of getting this done over the next 2 to 3 years is education. And it is a vital component for us to get that done. And these kind of webinars is really part of that leg. That's why you see that we address multiple devices in here. We really want to show what's available out there, because ultimately, looking at everything that's available, that will help us get to that mission of eliminating residual block. And that's really what these educational series are going to be about. So a big thank you to Prof. Lewald and Dr. Rodney for coming onto these webinars, and we hope to have many more of these in the future and really educate. There's a big gap out there to educate properly. So thank you for everybody for being here. It's really nice. As Stephanie mentioned, please send all your questions to us. Prof. Lewald and Dr. Rodney will gladly answer those offline afterwards, and we'll make sure that you get your answers to these things. So thank you very much, everybody. Thank you, Stephanie.
Thank you very much as well, and for your attention. And you're going to receive the recorded video so that you have a chance to look at it again. And as Roger just said, please feel free to come back to us with any inquiry, or if you would like to have a demo, whatever. So we are here for you. Thank you very much, and have a lovely evening.